Hi, everyone. I'm Christy Bird McKeeve, and I am the Executive Director of Butte-Glenn Medical Society, producing these virtual grand rounds every month. Someday we'll be back in person, but we're happy to be able to do these online for now. Just a quick note to keep yourself muted unless you're speaking. And the chat is always a great way to submit questions while you're thinking about them. We are recording this presentation. And thank you to Enloe Medical Center for providing the CME. We will be following up afterward with the CME information. And then also we will be highlighting Enloe Medical Center's programs. We were going to do that in the beginning of the presentation, but it looks like we'll put those to the end because they're having a bit of a problem logging in. And without much further ado, let me introduce Dr. James Moore and Jake Miller of the Substance Use Navigation Program at Enloe. I'm going to stop sharing my screen so that they can share theirs. As I said, we are recording this, so we look for a dialogue, but this is also, just be aware that we are recording. So go ahead and share your screen. And it looks like Dr. Philbrandt just joined. Hi, Dr. Philbrandt.
Hello. I'm going to mute though.
Yes, and I am too.
Sorry. Is that up there now, guys? We have to go back.
Looks good. You're on your learning objectives.
Okay. Well, thanks, Christy, for the introduction. Hopefully you can tell the difference in our voices or the slight movement of my mask to tell who's talking. So we're trying to be as official as we can, even though we're both vaccinated. I just don't like the smell of his breath for the most part. So we're going to keep the masks on if that's okay. So I'm James Moore. I'm an emergency medicine physician here at Enloe. I've been involved with California Bridge or Bridge to Treatment, whatever you want to call it these days. But the program that we're working here, we've been doing this for a few years. We'll go into a little bit more about the history later, but go ahead and introduce yourself.
My name is Jake Miller. I'm the Substance Use Navigator here at Enloe Medical Center.
So we'll take you through a few objectives we want to get through today. We do want to keep this pretty loose and conversational. So just at the outset, please feel free to interject with any comments or questions at any point. We have a pretty small group of people here, so I'm hoping even more so we can make this very conversational. But in general, some of our objectives here is we want to explain what the California Bridge model of care is, kind of the history of it, and where we've come with it at Enloe. Jumping into kind of our providers' approach to substance use disorder and how that affects some of the important clinical and social outcomes that we're looking for. Then we want to get in a little bit more to some of the actual interventions that we all can use to decrease stigma, the discrimination, and some of the other issues we have surrounding SUD treatment. Then at the end, and again, I'm hoping this is something we can open it up to the floor, but share some ideas about things we can all do as clinicians and providers and frontline workers to bring all these things into our own practices. So kind of the why do we care about all this? Well, if we just look at outcomes, of course, when we talk about substance use disorder, particularly opiates, we want to stop people from dying, but it's more complicated and not necessarily as sexy as that, as you'll see on the news, because as we all know, many of the users do have issues with other chronic medical issues that we need to treat. So bringing them into the fold of medical care in general is really important. So when we talk about the statistic here that patients with SUD are 3 more times likely to leave against medical advice, that's for all comers. That's not just patients who are coming in withdrawal. That's patients that are coming in with their heart failure, with their diabetes, with their other medical issues. But because their lives are complicated by SUD or perceived to be complicated, they end up leaving the hospital without getting the care they need. So we can all imagine what that does to health outcomes down the line and right at the moment. So some of the issues they might leave EMA out of the department or even upstairs once they're inpatient is that they're not adequately treated to curb their withdrawal and their cravings. Their pain is uncontrolled because, as we all know, a fair number of those with substance use disorder do have actual, treatable chronic pain syndromes. It's often difficult to tell the difference between those two, as we all know, but in particular, when you get up to the floor with a provider that doesn't have a lot of experience or will to learn about that difference, they're often treated differently and leads to these kinds of outcomes. Of course, the stigma and discrimination by the rest of the hospital staff, as well as just some of the more imposed restrictions by the hospital. For instance, someone with substance use disorder might find that they can curb their withdrawal by having a cigarette, but if the hospital policy is they can't go outside to have a cigarette, they're ultimately going to leave. And it's hard to fight that, and even to have a want to fight that. There is a line. Policies are made for a reason, but there has to be some give and take. And I'll tell you, from the emergency department, that's a point that's driven home every single day, trying to navigate the rules and exceptions and all those things. It's very complicated. Then, this is kind of obvious, but as I alluded to, every time a patient leaves against medical advice, it's a threat to their life, because just taking all comers, you don't know why they're there, but they could have a pending injury, they could have a pending illness that could make them deathly ill. So when they leave, that puts them at risk.
So the Enloe is affiliated with the California Bridge to Treatment, and their model, which is throughout the state of California at over 90 hospitals. There's, I think, almost 150 substance use navigators. They're also in clinics, primary care, or some of the medication-assisted treatment clinics as well. Some of those places have substance use navigators. They're not always called a substance use navigator, but we all fall under the California Bridge model. So their model is really about rapid evidence-based treatment, low barrier, and then part of what the substance use navigator does is the connection to ongoing care and follow-up. And then as a whole, a big part of the goal is to kind of create a culture of respect and dignity for the patients, so that they're treated as a person who's seeking medical care, and not just as a person who has a substance use disorder. So the bridge model drastically lowers the barriers, eliminates unnecessary tests, and provides patients in withdrawal with immediate relief. They simplify the process, which is what we have been doing here and continue to do. It's an ongoing work in progress. So one thing that's really important is a patient's not really going to engage very well in conversation about treatment and recovery and substance use disorder concerns and consequences until they're stabilized on medication. And then that's where the substance use navigator comes in to talk about that treatment, like how to connect them in the community. There'll be more on that. And often with lived experience, it is helpful. I mean, it's not necessary, but it is. But this population, it is helpful. They have very sensitive feelers, and when we sense that somebody is not being genuine, we tend to shut down pretty quickly. So then it makes the whole treatment conversation fairly difficult. So what is a substance use navigator? So kind of the goal is to improve access to MAT, where I'm embedded in the case management staff, and I work in the emergency department, inpatient setting. I also see folks at the rehab center, sometimes at our Enloe behavioral health unit. And really the big difference between having a son and not is that connecting them to the treatment and the follow-up support is a big one, because as we know, medical staff are always busy, as are the rest of the staff in the hospital. So having a person that's designated to pick up some of these important pieces is crucial. So what do sons do? Go in and speak with a patient. Sometimes I will be talking to patients before they even come into the hospital, and I'll meet them in the emergency department and make sure that they have the support right out of the gate, so that they feel comfortable, try to make the process as smooth as possible, like charge nurse know in the emergency department, start a conversation with the provider before the patient even is in the room, talk about, what MAT is, what programs and treatment options there are, and secure an appointment with that provider in the community, which often is actually, not often, but almost always is a much quicker appointment than if they were to contact the provider on their own. And community collaboration is huge, with, Butte-Glenn Medical Society, and the Opioid Safety Coalition, the MAT workers. I mean, there's too many to list, but they're all very important parts of being able to do this job effectively, and for these folks to get the support they need. So essentially, went over all of these. This is some, just a graph essentially pulled from, the data is pulled from the opioid, California opioid dashboard. So the blue line is Butte County's trajectory, and then the orange line is the state's trajectory based on opioid-related overdose deaths. And so the Butte County rate has now, in the past few years, has actually dropped down below the state rate, and was on a downward trend, while the state was continuing to rise at a fairly significant level.
I just want to make a couple comments about this graph, which I think is really telling. So if you look back in, say, 2015, 2016, and you correlate that line, if you look at how high Butte County's mortality rate was, we don't have the graph here, but one of the things that went hand in hand with this, we thought, was our prescription rate percentages too, which were skyrocketing compared to the rest of the state. It was kind of at that point that Andy Miller really got things going with trying to get, kind of a think tank together on, how can we turn the tide on this? Through some work with a few people, we were able to really get into the community and institute some safe prescribing practices and kind of holding physicians accountable to, to their patients and to the community. I really think when you see that line, turn gears, that had a lot to do with that. I don't think one person or even one group of people can really, take credit for it all, because as Jake alluded to, there's so many little outreach groups in the community, as he listed before, where, we're getting everybody involved. So of course, this is very much a team sport. And I think it's really evident when you look at this graph and you see all the steps we've taken as a county to make it happen, the benefit and change we've been able to achieve here. But then kind of on the flip side too, I also do want to make a caveat, because honestly, when this graph was put in front of me, I kind of did a cartwheel and put my hands up in the air, because I think it's pretty cool. That was really the ultimate goal. Was 5 years ago, we said, let's bring our mortality down, and this is exactly what we did. However, you'll see the graph stops in 2020. If we could continue on that to 2021, unfortunately, we'd probably see quite a change in the graph. So it does seem a little bit disingenuous just to tout how great everyone is doing here, when, to be honest, the fentanyl that has come into the community has probably sent this graph in the wrong direction again. I think still as a county, we're doing well compared to the state, but it's unfortunate that, if we're going to start looking at total mortality, it's probably going up quite a bit for all kinds of reasons. And, the fentanyl, which we all are at least loosely aware of, but then also there's probably been some effect of the pandemic as well. And, just to touch on that briefly, and I think, Chris, you wanted us to give kind of maybe a whole talk on that as an idea, but really, I don't know if, Jake and I talked about this, but what we think the effect really is that we're seeing, and I'd be curious to see if other providers agree, but, in general, I think we're seeing a big spike in substance use, not just in, opiates, but, our methamphetamine use are huge in the alcohol world. And as Jake sees kind of all of these patients in the hospital, he has a really keen sense of what that trend feels like. So I think in general, the pandemic has done that. There's also been some issues with access, but I mean, my opinion, I'd like to hear yours too. I mean, I don't think that was as tragic as initially we thought it was going to be, because I think the use of telemedicine, you know, we've maybe had to have a little bit more hands-on time in the ED because we're seeing patients a little more frequently on short-term bounce back as we try to get them in. But I think in general, the process still seems to be working okay. So I don't know. I don't know if anybody out there has any opinions on what they're seeing as an effect of the pandemic they'd like to share. If not, that's kind of my takeaway from it.
Yeah, I mean, it is hard to, you know, you can't really point to one thing being the cause of the rise. One of the main things I've heard over the last probably 9 months to a year is people have heard of being able to access treatment. So I think as the word has gone out there, that's been helpful as well.
Good segue into the next step.
Yeah. So this is kind of just monthly averages of patients based on the fiscal years. So in 2019, it's actually part of June, only a few days of June through December. I started this position in June, but it went live July 1st. But of course, I saw a few people before that. But as you can see, the trend is generally pretty up through June of 2020, and then when you're looking at like June 2020 on through is really when it started to pick up, especially in July of 2020, and then the first 3 months of this year were the 3 busiest months ever as far as number of referrals, number of folks with opioid use disorders, and number of people being initiated on medication-assisted treatment. I mean, historically, it was always somewhere between like 7 and 12, maybe 15 people would be started on MAD each month, and then starting to be in this year, it was like 27, 26, and so I think, you know, maybe it probably is that there are, you know, the pandemic is affecting things. I in my rosy mind, would like to think that, you know, that the word is getting out also, and folks are accessing treatment more than they would have before.
I think one of the additional things too, word is getting out, but it also seems to be recognized and, well, not only recognized, but not recognized and ignored, which I think was probably more of the issue 3 or 4 years ago. You know, let's say you're admitted to the hospital, the internist might say, oh, okay, you have a heroin use problem. Okay, well, that sounds like something you're going to have to take care of with your psychiatrist once you get out of the hospital for whatever. Now we're actually tackling that as a comorbidity and really taking that on while they're in the hospital or while they're in the ED. So I also don't get the sense that there's, you know, twice as many users out there now with use issues. I think we're just recognizing them twice as frequently.
There's a question if this is specifically Butte County data.
For which? For the line graph or the first bar graph?
Stephanie, can
The
you
bar
unmute?
graph for Enloe, that's all Enloe data.
And your patients come from 8 different counties.
Yeah.
Correct. Predominantly from Butte County.
Okay. Stephanie? Oh, okay. I guess we answered her question.
So this next slide is more specific to opiate use disorder and folks initiated on MAT based on percentage of the total referrals. Because I see people, for whatever reason, whether it be opioids, methamphetamine, alcohol, whatever it may be. So the actual percentage of total referrals that were opiate related went up significantly as well, especially the first 5 months of this year. And again, it's hard to say, you know, what the, you know, reason behind that. It could be that it's being documented more accurately. It could be that, you know, the providers have more of an awareness that is a significant concern for other medical conditions. So it's becoming something that, like, addressed more. It's hard to say.
So now we want to get into, the sort of the softer side of all this. The numbers, I think, speak for themselves, but, really the reason why we're affecting so much change is through these other talking points that I think are really important. So, talking about like a perspective shift and, challenging pre-existing stigma and discrimination regarding all this. So, talking about perspective shifts, we want to talk about the way we view a patient who's sitting in front of you. Very easy to label patients, to put them in a silo, and to treat them the same, assume certain things, that they all have the same experiences. But as I found personally, even if you just dive a little bit deeper into that, you'll find that those experiences are so varied. I mean, they're just as varied as every other patient you and I might see on a day-to-day basis, and where they come from, their family dynamic, their work status, their sexuality, all the things that stress all of us out are stressing them out as well. With the added complication is now they have perhaps a physical dependence that is making each and every one of those stressors even murkier. And that really impacts the way we deliver care to them, because, when you walk in the room and you're already thinking one thing, it's very difficult to, flip a 180 and kind of take their perspective on things. So I think one of the tricks I've learned is to, really try to force myself into their shoes. And that sounds silly, but literally I'll start asking them questions about what they've been doing today. What was stressing them out today? If I'm having a problem sort of getting to the bottom of where they're coming from, you'll find that, man, they just going through their day. It seems very stressful, and that often really softens my approach. And I think that's helped soften a lot of the approaches of the rest of the staff too, to sort of give them a chance. Because all these things can be affected by all of our histories, right? I mean, most of us have been in one way or another working with patients like this, or even just patients in general, for many, many years. And even before we got to that point, we went through schooling and education, which was just riddled with, patterns that you're supposed to adapt to, things you're supposed to recognize. And those are just fancy ways of saying how to classify people in one way or the other, right? So just like personal reflection. So, how do each and every one of us think and speak about people who use drugs? Because I think if we really pay attention to ourselves and our own speech, we'll find, we probably say things we clearly do not intend to say. I always tell Jake, I take absolute responsibility for this. He and I are supposed to be like the talking points about this kind of stuff. And I still catch myself sometimes getting caught up in a conversation and using a word that I'm turning around and telling people they shouldn't use. So, breaking those old habits is very, very difficult.
So stigma is one of the huge things that that patients experience, that they feel they're going to experience when they go into a hospital or medical setting. So this is just a definition of stigma, as linked to power and control, essentially looking at others as different from you and finding those ways. And it creates an us versus them, essentially, or us and them, which is what many people with substance use disorders feel before they even get into the setting. So, when I was speaking earlier about those sensitive feelers, we'll notice language a lot of language and a lot of nonverbal communication. And like I said, if we see something that's it's rubbing us the wrong way, we're probably not going to be very open. I think that for myself, being in recovery, it's much easier for me to not use the language as much, but I still have to be aware because, it's a medical environment and different terms are used that aren't necessarily always patient-centered, friendly, non-stigmatizing words. So even though it, is somewhat easier, it's still something that I need to remain aware of regularly. So what does stigma lead to? So we have stereotypes, which are the ideas, prejudices are the beliefs, and discriminations are the actions. So kind of just a breakdown of what those look like. So when we look at these, first we're looking at ourselves and our own ideas and how that led to the beliefs that we have. And then the awareness is how can we change those ideas and beliefs? And even if we think something sometimes, how do we remain aware enough to be able to change it at some point with practice, but especially don't let it come out in our actions? This is a negative cycle of stigma. So kind of when you look at this as, stigma and the sense of efficacy where you're not able to do it, and so you're going to be avoiding, resulting in anger, and then that whole I'm not good, and it's that endless circle for a patient, and it's just for a patient or a provider, and it's like, so why even try? This also can lead into something that we'll speak to later about, when your interactions with the same patient over and over don't result in effective change as far as from the provider perspective of what is expected.
And one other thing, I think even you could take this graph even further, and between all of those arrows, just insert another arrow that says return to substance use, because dealing with all of these questions often leads to using again. So I feel powerless, I'm unable to change. Well, at least I have my habit to make me forget about it. My self-esteem is no good. Well, at least I can go back to my drug use again. They were judging me in there. I feel more powerful when I'm high. That kind of thing, right? So we'll just point out some case studies, and I know a lot of this seems kind of over the top, and we kind of considered cutting it out because it seems almost hokey and you're trying to be funny, but then I think back to actually hearing, nurses and staff say these things, not in the too distant past. So I think it's important to point these out because maybe you agree or don't, but I think this really drives the point home of all this stigma we're talking about, right? So statements like, I've been hooked on pills ever since I injured my knee, and I'm using heroin. They come in, they say, I'm sick, I need help. And, the response, as you can see, oh, we have this heroin addict. They say they withdraw, but they don't look so terrible. They're not vomiting or anything. I don't really know what their secondary gain is. They probably just are hoping they'll come in and get a refill on their Norco or Percocet. I'll just say it's kind of funny because I think we both noticed that even just in the past few years, I think the thought of hearing something like this now would be very surprising. But even as recently as 3 years ago, I don't think I would have been surprised to see this exact conversation unfold in front of my eyes. So I do take that as a plus, but I still think this is very prevalent, if you would agree. So something more appropriate that you could say to hand off your care to the next staff member would be, I just grouped the patients at 10, 32-year-old with a chief complaint of heroin withdrawal, vital signs are stable. Now this sounds very much like any other medical patient you would have who came in with a chief complaint. I have a diabetic with a high blood sugar who doesn't feel great. That would not be out of the ordinary, so why should this feel so forced?
So how might this patient feel about coming into that medical setting again if they were treated like that the previous time? And then, what do those consequences look like?
That again goes back to the leading against medical advice or just general distrust of the medical system. So if we talk about this just being discouraged from seeking treatment, those points are all being made again. They're going to be much less likely to come back in and seek care, whether that's in the emergency department, the hospital, to their primary care physician's office. And again, it goes without saying that these patients have illnesses just like everybody else. And, if you would give someone a hard time for not refilling their high blood pressure medications, you can understand why it would be important if these patients didn't follow up as well.
So they're also more apt to drop out of treatment. So, I mean, there's a huge burden of stigma, the fear of judgment, that people with substance use disorders are less likely to seek help, more likely to drop out of treatment programs in which they enroll. And it's, you know, it's a huge piece of it is when you're feeling like you're being treated normally, because, you know, a lot of folks that have substance use disorders, you know, are treated differently. So when you go somewhere and you're treated like that, it's really reaffirming that, it reaffirms all those insecurities about, you're not, you're not valuable to the community you live in, you're looked down upon. Whereas something as simple as just you don't have to lift someone up in that situation, but treating them as if they were just like anybody else, which they are, is enough to really have them feel, empowered in a sense, that they're so used to the negative that even just something that's neutral is a positive.
I'll make another point too, just going back to the success of our own program at Enloe. I think our 6-month retention rate is somewhere around 70%, if I'm not mistaken, for patients that begin treatment, which I think actually speaks highly of Jake, honestly. So he talked about his roles, and he kind of glossed over what I think is maybe one of the most important things he does is that follow-up after we see them, because, ideally we wouldn't see them back in the emergency department again, assuming they go to the appropriate clinician outpatient. But the truth is, patients fall in and out of treatment all the time, and we end up seeing them back in the emergency department multiple times. And I think the fact that Jake calls to check up on them, see how they're doing, not just in the days after, but weeks after and even months after, I think really helps establish that sense of importance in these patients when they might not be getting it anywhere else. So, I think all of us who have patient contact should also keep in mind that we probably don't realize what a positive impact we can have even in just 1 or 2 isolated instances with them in fostering that trust that they have in the medical community when they're probably still surrounded by so much negativity.
And I think it also points to the quality of programs that are available in our community. I really believe that, because there's a lot of people in the substance use treatment world, for almost always are there because they're doing it from their heart. It's something they want to do. It's not typically the greatest pay you're going to get or that you could get. So your reward is more about helping others, and that's what the field is about. And I think our community has a lot of professionals that's their goal.
Sorry to interrupt you guys, but we have a couple of questions in the chat. Dr. Phil Brandt, can you unmute and share your question? Because this is being recorded and it'll be good to have your question asked verbally.
Okay. Yeah, my specific questions, I have others if we have time later. One is on the chat there. What are our current barriers in the program? Either both at Enloe and in the community. Secondly, how does the Enloe program compare to other programs in California or wherever? Or how is it different or not? And also, do we have metrics to compare ourselves to others? And then a third thing that came to mind, just curious about it, do we see repeat patients occasionally? And I'm sure the pathway is the same for those that circle back, because people do circle back sometimes, I suspect.
Absolutely right. You want to see that? Barriers?
Yeah. The biggest barrier that I found is really, for some folks, well, through the pandemic, the hard thing is providers were doing, some providers were doing services exclusively over the phone and, Skype or Zoom, and a significant, percentage of this population, no surprise to anybody, is don't have access to telephones, or they're homeless, and they, people steal things, they lose their phone, it gets stolen. And early in recovery, just being organized is not, something that typically you've had a ton of practice at. So, organizing, making sure that you remember those appointments. Like I will call and give reminder calls, but like I said, not everybody has a phone. And then you're looking at how else can it be done, and it's difficult. Another difficulty is just the number of options for where to refer folks. We lost one provider in the community who was essentially one of the main, one of a couple Medicare and private insurance providers that had programs. That's a difficulty. Another big difficulty is folks from out of county, because we do get a significant number, especially from counties that don't have any program. I won't say which counties those are, but it's very difficult to get them involved. But I have pretty good relationships with folks in those counties, so they're at least following that patient once they're out of the hospital as well, and helping to pick up those pieces around the resources in their area, because I'm definitely not going to be as much of an expert as they would be.
That, again, goes back to the importance of our community relationships and all of these meetings that we go to, because fostering especially cross-county collaborations is really important. Now we're, because of one of the reasons that, the X-waiver is easier to obtain, for instance, and now this is getting so much more attention, thereby some more funding, we are seeing a slow but steady increase in the options that you have. It's still not where we'd like it to be, but certainly we've made a lot of progress in that over the past few years. And to address your last question about patients that come back, we've really tried to take a universally non-judgmental approach to patients that, for whatever reason, either short-term or long-term, fall out of treatment. So, it could be as simple as they missed their last appointment yesterday and, can't get seen for 3 or 4 days, all the way up to, maybe we started them 3 months ago, they were in treatment for a month, and now they're back after having been using for 3 more months. And you're right, they're treated just the same. And if anything, they get more cheerleading, because many of these patients have tasted what it's like to be sober, and they remember that, and they like it. And that's why they've come back to ask for another try. So again, that's really been the evolution, is treating those patients with just as much respect as the first time, and not falling into that trap of, what do they call it, moral, we'll get to it. There's a word they're using. It's like this moral dilemma where, inherently, even if you want to give patients infinite number of tries, it's a bit painful to come in and have to think, oh man, I spent 3 hours last time making this all happen, and you didn't take advantage of it, so why should I spend 3 hours again? It's that sort of general sentiment that we're all battling.
As far as the metrics, I track a ton of data, and we do not compare ourselves to other programs. That is a good thought, actually. But pretty much all the programs follow the same model, and we meet at least once a month over Zoom at this point, all the programs under the California Bridge, and talk about things that are going on and changes. And so that also is a great network, especially for folks that aren't from our local county areas, like folks from Southern California, and I can just contact the substance use navigator there, and they'll pick up the.
So one thing, I know we're running a little short on time, and we don't have time to get into all the slides we have, but I think I just wanted to pick out a couple of things, to continue talking about the stigma, and, what we can all actually do, in our own day-to-day lives and practices to affect change here, because we don't work independently. We're one piece of the patient experience when they come into the clinic or the hospital, and often we're the last piece, and sometimes the patients have even left before we see them because of all the things that led up to their discouragement, right? So one thing I'd like to use as an example is just to try to be very intentional. We talk a lot about the right and the wrong words to use and how difficult that is, and how it often feels very forced to say things that are basically counterintuitive to the vocabulary that we've developed over 45 years in my case, right? Like using words like alcoholic is almost, you want to say, what's the harm in that? But we break it down, it's a label you're putting on somebody. And that could be thought of as a medical condition, just like substance use can be thought of as a medical issue. So using words like addict and abuser, that has all been shown to have such a negative connotation. And whether or not that's your intent at all, that's what's taken away from the patient, and then that's all full circle about the outcomes there that we've been talking about. So I guess in general, my challenge is to be very intentional with your speech, even at the point of feeling uncomfortable and almost phony. Like using words should feel like you're learning another language, because it really is. But the only way to spread that around is organically, because you can try to punish people for using the wrong words and scolding them. But, that's not very fair, because, most people are coming from years and years and years of experience that we can't expect them to change overnight, but you can change by watching other people use the language and letting them be the canaries who feel uncomfortable so that it's acceptable. So, I would like to say, for instance, I challenge all of you to make a personal goal to make one small change in the way you talk about these things at work. Whether that means, not using the word alcoholic, even with the best of intent, using alcohol use or misuse or something along those lines. Certainly trying to avoid the words, addiction or addict or abuse, which is difficult because we laugh, ICD-9 still has the term, heroin abuse as a diagnosis. And if I want to find, opiate misuse or opiate use disorder, it's like impossible. So it's a difficult thing when such large forces seem to be working against us. But I guess that makes it all the more rewarding when you can make change in your own little environment. So I would challenge you all to go back to work and in the next couple of days, try to say the word substance use disorder 5 times out loud where people can hear you say it, just so you get comfortable saying it out loud and other people become comfortable hearing it out loud.
Can I also,
even-
sorry to interrupt again, but Stephanie had a great question about whether you provide this as a training, and if not, might it be an OAK presentation, which I'm not familiar with, so.
OAK is our internal training module on the computer. I think that would be great if it was in there, and people were even had the option of looking at it.
I'll speak to that actually.
Yeah.
So, I don't know, Enloe participated in this CalCompare. It's an organization that basically recognizes hospitals for doing good work. Last year, Enloe applied to be on the opiate honor roll, which we did make. And I bring this up because we'll be reapplying this year. And one of the ideas we came up with last year that we haven't quite made come to reality is just exactly what you're talking about, an OAK module, whether it's optional or not, to roll out to the staff. It's tough because when you bring something like this to the table, you're fighting a lot of battles, right? I mean, we all know that. When you're dealing with administration, there's still so much hesitancy to take something like this on because no one wants drug addicts coming into our hospital, quote unquote, right? I mean, that's the sense that we're trying to battle. It starts from the top and has to work its way down. But when you get something like a medal or a ribbon that they get, all of a sudden it becomes much more enticing for us to roll out programs that will help with that. So using that kind of idea as an essential component of how we're going to score well on this honor roll system and get an award is very helpful. So it's a great suggestion. I hope it's something that we can continue with.
Also, Eloise had a question about, and thank you for taking Glenn County residents. Eloise Jones, as you probably know, is from Glenn County Behavioral Health. So our question is, do you have any data on the number of individuals who get inducted onto Suboxone who have a successful linkage to an ongoing MAT?
Yes. Like as far as actually showing up for their intake appointment? Yeah.
Yeah. Now, you do a phenomenal job with the referrals. I'm just wondering how many people actually engage with an ongoing provider. If that's possible too.
That is a number that I would love to figure out how to get higher, because it is a low, I mean, you're looking at, you know, tops, the top would be maybe 50% of the referrals will show up the first time. You know, a lot of folks come back through eventually, and it seems like the number is much higher that eventually will engage, but that initial first attempt is difficult.
We tell that to patients too. I mean, you know, we all want it to be 100%, but again, when the patients come back in that second time, you know, at least personally, I'm such a cheerleader. I'm like, I'm so glad you came back, because you can see that they recognize what's possible, right? So even if it didn't, you know, kind of take the first time, they all tried the Suboxone. They know what it feels like to think like they haven't felt in years sometimes, right? They told me that within 45 minutes. I haven't been as clear in my thought in 4 years, and we're crying. It's pretty amazing sometimes the stories you see. But we tell them, man, hey, this is your second time. We see patients in here 4 or 5 times before it really sticks, you know? So, you know, you don't want to tell them that they should take 4 or 5 times, but I think most patients in general appreciate that honesty when you say, you know, it is not a failure, it's a tripping zone along the way to what most people ultimately find to be successful recovery. So, you know, he says 50% is a failure, and I guess that's, I don't know, that's our pie in the sky. But honestly, I think 50% is still very successful. I'm going to say that. I'm hoping it was 70 or 80, but I think it still is pretty amazing that it's 50% when we didn't even have anything like this 3 years ago. It would have been 0, right?
No, that's actually great. I appreciate the information. And just for outpatient treatment, 50% of our referrals show up for an intake after we've already made an appointment. So that if your highest end modality, the MAT, is actually showing up with the same as an outpatient, that's great. So
That's a good
great job.
Any other questions? I know we're already keeping you guys over. Sorry, and appreciate your attention.
I think we're all good. We're good for another 15 minutes.
Okay, good. Any other questions? I guess I'm just curious, if I could just open it up, what other people's experiences are in your respective clinics, you know, regarding sort of general staff attitudes. I mean, all the people on this call are clearly more interested and maybe motivated than your average person to take the time, but what's your general sense? Do you all find there's a couple, you know, sticks in the mud that aren't ever going to change the way they think? And how does that affect the rest of your staff? Anyone want to comment?
I'll just say from Glenn County, one of our challenges, like with this level of care, is the intersection between mental health and SUD and crisis. So a lot of times we're having people access after hours crisis, and just the difficulty of people either presenting in what appears to be at first a mental health like 5150 type of scenario, and they're under the influence, and it's an acute significant substance misuse impairment. And so what to do in that case? And people, a lot of our mental health professionals, oh, well, they're just addicts. We can't do anything. They're not going to change. And so that stigma, actually, in confronting it, is something that we're like actively trying to kind of work on, and the training about that, and how to actually access the higher levels of care within the SUD continuum. And, you know, like, just, it's really clear. I was talking to one of our crisis workers today, who's fabulous, you know, I'm like, oh, I really need to go and train again to our crisis workers on how to access Enloe, what types of services we would send to the, you know, to the bridge, to the son at Enloe, at what times. And then what after that, what are our preferred referral sources for MAT for ongoing care, and just making sure that they even have the right information. But that's what I'm finding, the intersection of mental health and SUD.
Huh. I mean, I guess it's surprising. I shouldn't be surprised, but I guess in my brain, I would think they would have in general, would have a more keen understanding than your average clinician or average provider on how intimately these problems are all coexisting, right? So,
I think there's a lot of training needed for the mental health professional about how to work with SUD, how to understand it, identify it.
I mean, that is one thing that is obviously so important, is that coexistence of mental health with substance use, and how one begets the other, does it not? I mean, that is not just a coincidence. So to bring those two together seems like it'd be more important, I don't know, than anybody else, really, to be able to put those two together well. So,
I mean, from my experience and probably many others, and you know, folks with substance use disorders, if not initially, eventually, a vast majority are using substances to feel relief, essentially, whether it be from mental health, pervasive mental health conditions, or just negative emotional states, trying to fit in, feeling, you know, whatever it is, mild anxiety, whatever it is. And, you know, I tell patients almost every single time that, you know, likely there's likely something underneath there that's, you know, that's kept us doing what we do. And in order to, you know, achieve that long-term abstinence, that it's going to eventually have to be addressed. Not right away, obviously, but, you know, just to warn you, it might come up. And I'm a kind of visual person with examples, and saw, well, maybe not the younger folks, I'm going to use the example of the whack-a-mole game like they had at Chuck E. Cheese, because the younger folks may not know what that is, but that's kind of what those feelings are. That's what I explain to people, is, you know, they'll pop up, we'll push them down, they'll pop up, and so I think that mental health piece is huge amongst this population, definitely.
Just a suggestion, maybe that's a good topic to bring to the Butte-Glenn Opioid Safety Coalition as something we might try to do more, you know, help with more in the future.
Nice idea, Chrissy. Thanks.
I mean, I spent many years at the you know, our county's behavioral health, and worked on both sides with mental health and substance use disorders, and the crossover was huge. And you know, the philosophies vary probably still from county to county on, you know, if there's a substance issue, do they go treat that first? If, you know, if they're there for substance use disorder, can you really treat the substance use disorder if mental health isn't being treated? And, you know, all the evidence shows that they need to be treated together, but somehow all these years and years and years later, it's typically not the way it's done. And it really is a crucial part for success in either side of that. And they complement each other. They're not opposing forces.
I've heard if someone's homeless, they are less likely to be able to adhere to an ongoing medication, you know, their ability to take care of themselves. I think you talked about this a little earlier, but I'm just thinking through how that's a real big barrier for someone to actually get the treatment that they need, whether it's for their mental health issue, you know, the mental illness, or a substance use disorder. So that's just an amazing feat to then have someone stick with a program. I don't know, just commenting, I guess.
no, it's actually very relevant. And it's a discussion we've been having a lot more recently, just addressing that inability to follow up, just from like a transportation, you know, standpoint. Just start with that, right? So again, the whole idea is, you know, all this is go to the patient, you know, go to where the patient is at in life, in their mind space, in their physical location. So, for instance, I'll just, you know, shout out to AMPLA, because we've been having conversations recently regarding their mobile medical unit and how we might be able to kind of manipulate, for lack of a better word, the ability of them to have an ex-waivered provider, for instance, that could go to, say, the shelters once or twice a week and set up ongoing appointments to take out that huge barrier like you're talking about. So yeah, I mean, it's a huge point and one that hopefully we can make some headway with in the near future. Anyone else?
Interesting.
Okay, well, we're easy enough to find, I suppose, with specific questions about, you know, your own patients or just how the process works, or suggestions on how we all can collaborate better as a community to do right by our mutual patients. You know, there's multiple avenues to reach the community. We've got the Opioid Safety Coalition, we've got the MAP provider group, which are essentially open to anybody. Christy, if you could just have people contact you if they're interested, and, you know, we can get them in touch with the right people, whether that be Josh Williams, who kind of manages a lot of these meetings, to get you out some invites, or put you directly in contact with Jake or myself. Clearly, neither one of us minds answering questions or collaborating. In fact, I think that's what's making this whole thing work, is people reaching out. So,
Yeah, my contact information is public knowledge. It's on Butte 211, it's on our brochure. I hand my cards out constantly, so that works. Cell phone number is the best way to get a hold of me, and anyone can call.
Appreciate it. I just put my email in the chat. I think most folks on this presentation know who I am already. I want to say thank you for your presentation. We have our annual virtual opioid summit. I don't know if it's always going to be virtual, but it will be virtual again, September 15th at 4 p.m. And I think we should have you both present on stigma in this, you know, really spend some time presenting to the larger group. We'll probably have more people involved in that. And then also just to note, Healthy Rural California met on Monday night. Our board met on Monday night, and we voted to give our next Public Health Excellence Award to Dr. Moore and Jake. So we'll be presenting that at our next board meeting in September, and just really proud of all the great work that you've done. I mean, you know, as you've noted over time, this program is helping more and more people, and that's just a beautiful thing to see, and we want to thank you for that effort. The Butte-Glenn Opioid Safety Coalition also did apply for the Layton Award for the SUN program as well. We may not hear about that until later in the summer, but we're doing all that we can to support you all.
well, thank you very much, Christy. It's quite the honor, honestly, but I mean, it's not just hyperbole to say that this is only successful because we have a community that we can rely on to take the patients that we see. Otherwise, this would go nowhere, right? So that goes without saying. So thank you to all of you out there too.
Take the village.
Does anybody else have questions or?
No, just thanks. I really appreciate what you guys do. Doing a good
Well,
job.
thank you.
And I appreciate the data. Awesome.
All right, well, thank you all so much. And thank you, Dr. Moore and Jake, for always taking this leadership role in making this happen.
Thank you.
Thank you.
Okay. Thanks, everybody.